Pleasure for me to introduce our last speaker, Andrew Wright. Andrew's a hernia and data science colleague. He is the director of the Hernia Center at the University of Washington in Seattle, Washington. And as part of his duties, he coordinates hernia care across multiple hospitals within that system. So thank you very much, Andrew.
Well, thanks, everyone. I want to jump right into it because I know we're running a little bit behind. I do have a couple disclosures. These are in the hernia-related space, but none of them actually affect this talk. I want to start with two quotes, and I want to keep this talk very practical. So the first quote from 1948, "A surgeon can do more for the community by operating on hernia cases," and I'm going to change this, seeing that her recurrence rate is low, then she can be operating by a case of malignant disease. We see this all the time in the communities, but I think it kind of takes a back seat sometimes to the more glamorous colorectal and oncologic procedures. The other quote's attributed to Tip O'Neill, former Speaker of the House: "All politics is local." And I think all ERAS pathways are local and all quality improvement projects are local. And I think when we look at these big national and international guidelines, we really have to talk about how we implement that in our own local institutions. So I'm going to try to frame all of this in a discussion sort of our process of developing hernia-related protocols, especially because there are no published guidelines for hernia-related ERAS pathways. So just that background, we are a 4-hospital system. I primarily work at the University of Washington. We do have established ERAS pathways that we were able to piggyback on, but we were really trying to transform hernia care across the entire system, and that involves Harborview, which is our critical access hospital. They had a very different model where they have one single ERAS pathway that covers all abdominal surgery from soup to nuts. And then we have 2 other hospitals that are newly integrated in our system, really no background in ERAS, and completely different cultures, different EMRs, different purchasing, really adding to the complexity of formulating these plans. In that context, we have a rapid growth in capitated care in our system, 10% this year, projected to be 20% next year, mostly based on big employer contracting. What they really care about is access to care and return to work. They don't care about RVU generation. They don't really care what we do in the hospital. They just want their patients to get back quickly. And that's created an intense pressure in our system to develop, to demonstrate value to these employers. So a lot of the benefit of what we're doing in these pathways isn't just for me, isn't just for my patients, but it's actually to the employers and to the insurance companies. In that context, the UW has gotten a big grant from CMMS for this Transformation of Care project. I can't take any credit for this. I didn't write the grant. I'm not on the grant, but I'm involved in a lot of these projects. And the idea of care transformation is to look at the entire process of care around some disease processes from the outpatient side to the inpatient side. So it's sort of taking ERAS, but expanding it across the entire system from the first point of contact of the patient until they get back to work. So I'm going to talk about that ERAS pathway sort of in the traditional model, but really in the context of that transformation. That transformation has sort of 3 parts. One was the contracting and material management. The other is really a standardized approach or a sort of more uniform approach to preoperative evaluation, management, optimization before they ever enter that ERAS pathway. And then the third is the more traditional ERAS perioperative care pathway. So just very, very briefly, the contracting materials management really required a team approach, so it's not just the accountant sitting in a room. This involved having the surgeons involved in the process. I'm a huge musical theater nerd. I love Hamilton. If you know Hamilton, you got to be in the room where it happens. So being in the room where this happens, the mesh contracting was critical. And what was critical is when we developed our request for proposals, we made sure that quality and service were equal in the weighting of the RFPs, equal to cost. And because I was really there, quality in the RFP was defined by us, the surgeons. And I think that was really important. And that's projected to save us about $300,000 a year. On the pre-op side, before they enter the ERAS pathway, this was really a process of consensus building, and it really grew out of the Strong for Surgery program, which was developed in Washington State by a good friend, Tom Varghese, and has now been adopted by the American College of Surgeons. So this is really an approach to taking a patient and making sure they're fit for surgery before we ever get them into the operating room. There's also been an element of coaching and mentoring so that we're getting physicians across multiple hospitals to come together to expand their practice, to get them involved in more advanced levels of care. So some of the key factors in this: smoking cessation, managing patients with morbid obesity, the nutrition, glucose control, and then risk stratification and management. So I'm just going to step through a couple of these things. We know in the hernia space that tobacco doubles your risk of SSI. It increases your risk of recurrence. So we are making sure that we're checking and monitoring patients for smoking. Obesity, we know dramatically affects, again, SSI rate. As you can see here, once you get up over a BMI of 40, your relative risk of a SSI goes up by more than threefold. So there are some cut points here that influence what patients we operate on and how we manage those patients in our clinics. We also know that obesity dramatically affects recurrence rate after hernia, so that, again, just emphasizing the importance of this, which is a public health epidemic. So what do we do for patients to come into our clinic with morbid obesity? Well, for elective surgery, we're referring them to our medical weight loss center or to our bariatric surgeons, depending on the desires of the patient. And we have a plan for how we're going to try to get them to a BMI below 40. A couple of important points: if you tell a patient, go away, you're too fat, come back when you've lost weight, you've lost them forever. They don't like you, they'll never come back, they won't lose the weight because they don't have any motivation or goal. So we try to make this a process where we're working with the patient, where we set goals that aren't necessarily number of pounds, but are really more functional. And we bring them back, or at least I bring them back every 3 months, because I want to check in, see how they're doing, give them that motivation to keep working with the program. So just some data. This is from Mike Rosen's group in Cleveland, where they have a very similar protocol of a medical weight loss program, and they've shown some excellent results. So they can take patients with a BMI of over 50, referred to their hernia center, get them enrolled in a medical weight loss program, and get their BMI down below 40 prior to surgery within about 6 to 12 months. So really pretty good evidence that this is a viable approach for these patients. We know that diabetes dramatically increases your risk of SSI. Interestingly, it's protective for mortality in the hernia world. But glucose control is important, and we won't operate on somebody who has an elevated hemoglobin A1C. Immunonutrition, we don't have time to get into all the data. There's no data in the hernia world, but we're really extrapolating from the colorectal literature. And then I think medicine consultation is critically important, and this is something we leave out a lot because it happens before they enter the ERAS pathway. This is a study from Hopkins looking at outcomes before and after implementation of a medicine consult service. So this is a service that sees the patients in the outpatient world, gets them ready for surgery, and then follows them in the hospital, and showing improved length of stay and decreased complications in patients who are brought onto a medicine consult team. So really that collaborative work with a patient. So here's our strategy: no elective hernia repair in smokers, and we do check urine cotinine. Anybody with a BMI over 40, generally, it's a little bit of a soft target. We refer to our medical weight loss or our bariatricians. Immunonutrition, MRSA screening, everybody gets a hemoglobin A1C and a comprehensive metabolic panel for screening, and then liberal use of medicine consultation for anybody with significant comorbidities. So now we're rolling this into our ERAS pathway, and we're moving into sort of the more traditional perioperative formalized pathways. This really required, so building out this pathway really required that multidisciplinary team. So it's not just surgeons or anesthesia, it's nutrition, it's physical therapy, and it's administration. And some of the biggest barriers that we've had have actually been in IT support, building out program dashboards to measure compliance, for example. So here is our pathway. This is on the Sage's Smart website, so this is available. You can go on and download it, take a look at what we've done. Rebecca Peterson's actually in the room, and she was really integral in making sure that this happened. And I think it's important to note here on our, I don't know the laser pointer, but on our pathway, the first item on our pathway is the Strong for Surgery pre-hospital clinical intervention. So that's rolling in all of those pre-op optimization piece sort of into one bullet point on our pathway. We don't have time to go into everything, so just a couple of highlights. We do the carbohydrate load, fluid restriction, glucose control, advanced pain control, all the things that are in a lot of other ERAS pathways. Regarding advanced pain control, gabapentin pre and post-op is routine. And our pathway calls for an epidural, although lately we are having a lot of surgeons go off pathway and doing exparel tap blocks, and I think that's something that we may change in our pathway moving forward. This is the the day of surgery and post-op pathway. Again, this is all on the Sages Smart website. And a couple highlights here. Again, continuing the epidural, continuing the gabapentin, getting that epidural out early mobilization, early diet, and then that discharge planning. I think really as important as the pathway is the patient education. It's really the pillar that underlies all of this, because if the patients don't know what's going on, then it doesn't really get you anywhere. So we put a lot of focus into our patient-friendly care maps. All these are also available on the website, and these include sort of a day-by-day, step-by-step plan that the patient knows about and follows. And this is actually laminated on the whiteboard in their hospital room, so they know what's going on each day. Just to show you some data on our results, this is not published data, and I don't have permission from the hospital to show it to you, so don't let my administration know. Our average length of stay before and after implementation, about a day, 1.2 days saved in length of stay, and our O to E ratio improved as well. We had no mortality pre or post-op, so that's kind of nice. Our average direct cost dropped by about $2,000, a little bit more than $2,000 a patient, or 15%, and our O to E direct cost is still higher than expected, but we've gotten that closer to an O to E ratio of 1, so that's a benefit. And our readmission rate during this process has actually dropped, so we're not sending the patients home too early. A couple more days. So the red line is our implementation date. So this is off our dashboard, and you can see that our volume after implementation actually went up, so reflecting an enhancement in our business. All this data, by the way, is from only one of the 4 hospitals. The length of stay trended down, but more than just downtrending, if you notice after implementation, you see there was a high degree of variability before, and that variability is really smoothed out afterwards. And that has a lot of implications for bed control and throughput beyond just the strict number of days. And direct cost, again, similar phenomenon where you can see a big change in variability, and then that smooths out post-implementation. There's only one paper that I know of that shows any results in hernia pathways, and this is from Novitsky's group, and it shows similar data on length of stay and readmission. They don't have any cost data in this paper. So what are some of the barriers that we've hit? The biggest thing has been culture across multiple institutions, working with the purchasing, the coordination, and I would say some orneriness, and in fact, of the 4 hospitals, one has basically completely refused to work with us and has not implemented any of these procedures. IT has been a big issue, especially working across multiple EMRs, and we really don't have a mechanism for monitoring compliance. And I think one of the previous speakers, Dr. Hutter, mentioned that was important. We have no idea of knowing if somebody's getting their pre-op carbohydrate load. And we've now moved into this phase of maintenance, of having these periodic stakeholder meetings and revisions to the care maps. I think the biggest 2 questions we have right now are epidural versus the tap block. There's some evidence presented at the American Hernia Society last week that suggests that epidurals actually increase your length of stay in the hernia world. And chlorhexidine, the pre-op night before chlorhexidine shower, again presented at the American Hernia Society, actually increases SSI rate. So we may actually be dropping that from our care map soon. Thank you very much. I'm happy to answer questions, and I think we have a panel too, correct?